Thank you. May I invite Professor Chen? Are you there?
Yeah, thank you, Dr. Chen, Dr. Ye, and Dr. Zhang invited me to join this meeting, and thank you, Professor Philip, for your excellent lecture. So, from my perspective, treat to target in SPA should be a universal principle, but not a single rigid target. So, in PsA or axial PsA, we need a domain-based approach that integrates clinical index like imaging or inflammatory biomarkers and etc., especially the patient-reported outcomes. So my question is, in real-world practice, when these measures are discordant, for example, the MRI or CRP improves, the patient still reports some significant pain or fatigue. So how do you decide whether this is persistent inflammatory disease we need to require treatment escalation, or just like you mentioned, the other complex to manage phenotypes such as fibromyalgia, such as depression, or like central sensitization? And what do you consider this minimum practical targets to daily clinical practice, especially in some certain terms like healthcare system limited for reimbursement or MI access?
So you do highlight a particularly difficult case to analyze. Here we have a patient who is on an immunomodulatory therapy that you think should be effective. Maybe it has been effective for the patient, but then the patient has now developed more pain, a bit more fatigue, a bit of sleep disturbance. You do an MRI scan and it does not light up. There's no evidence of inflammation on the scan. Is this inflammatory disease nonetheless, even though the MRI doesn't light up? Well, we know the MRI isn't perfect, and there have been cases that we've treated where the MRI has been basically negative, and yet they've responded well to a treatment like a TNF inhibitor. So this is where the art of medicine comes into play and your ability to read the patient. And I think that you can pick up a lot by just kind of observing, talking, and getting a feel for whether this person has a certain degree of fibromyalgia-ness that may respond to a fibromyalgia treatment. But if we fully are confused and just can't tell, we may do something like the following. Let's pretend that the patient is on adalimumab every other week. So we may go through a period of, say, 2 months where we'll give them samples from our clinic of an adalimumab pin, and we'll ask them to take adalimumab weekly for two months. If there's absolutely no change in their symptoms, then we may drop back and say, well, maybe this isn't active inflammation that's not showing up on the MRI scan. And we may then turn to trying a therapy like duloxetine, which is an SNRI serotonin norepinephrine booster, or we may try the sublingual cyclobenzaprine that has been recently approved, or we may try a medicine like gabapentin, just to see if there's a pharmacologic reaction to one of these adjunctive pain analgesic medications. And then we'll just see what happens. But I think that if you have a negative MRI scan, you at least are not as worried about having progressive structural changes, structural damage. And so at least you can fall back on that and not feel that strongly compelled to switch mechanisms. At the end of the day, you may end up switching mechanisms, and if the patient has a good response, you'll stick with it. If they don't, more reinforcement for the idea that it's not inflammation causing the pain, the residual pain.
Thank you. And my second question is, in Axial PsA, actually the clinical and radiographic phenotype may be quite different from the classical ankylosing spondylitis, including like the asymmetric sacroiliitis or like sometimes less typical inflammatory back pain. So do you think the Axial PsA should be follow the same treat to target strategy as the radiographic ankylosing spondylitis? So do we need a separate target framework for those Axial PsA?
So axial PsA is we're now studying much more closely. We've just completed a major project called the Axis study between ASAS and GRAPPA, where we studied over 400 patients with psoriatic arthritis and characterized their axial disease. 27% of them were considered at the end of the day to have axial PsA. And we ended up relying quite heavily on imaging results. They weren't the same imaging results as with axial SpA. I highlighted a few of these in the talk, like asymmetry of sacroiliac involvement or no about 25% of the patients did not have any sacroiliac involvement, but did have involvement further up the spine as evidenced by imaging. So I think that, and also the other point is that axial PsA occurs a little bit later in a person's life than axial SpA. Classic axial SpA patient is a male in their late 20s. The axial PsA patient may have had PsA for 5, 6 years and then start developing back pain in their early 40s. About the time that they're starting to show evidence of degenerative arthritis in spine imaging. So it becomes more difficult to sort out, is this degenerative arthritis, is it fibromyalgia, or is it axial PsA? I don't know what to say. There is, as you know, there's the whole issue around IL-23 inhibitors not working in axial spondyloarthritis. I think that's pretty much accepted. But I think it's still an open question about IL-23 inhibitors in axial PsA. We saw a signal for improvement in the guselkumab phase 3 studies in patients that were considered to have axial PsA by their investigator and had imaging changes of the sacroiliac joints felt to be consistent with sacroiliitis. So it was an interesting group of patients that showed improvement with guselkumab in their symptoms. So we are now awaiting the results of the STAR trial, which has very well characterized axial PsA patients by MRI who are being treated with placebo or standard of care versus the use of guselkumab. And I think that that's going to be a very important study for us to know whether IL-23s work in that disease. Until then, we have to rely mainly on our drugs that we know work in the spine, including the TNF inhibitors, the JAK inhibitor class, and the IL-17 class.
Thank you. My last question is, given the upadacitinib data in PsA or both like radiographic or non-radiographic axial SpA, so where do you think the JAK inhibitor should be the first line as the TNF blocker or interleukin-17 blocker, or just in specific group of patients as the first line?
Yeah. So I think that the data overall supports, again, we're excluding patients with concomitant inflammatory bowel disease. Then I think the data results show similar efficacy between the IL-17 inhibitor class and the JAK and upadacitinib data. So I have confidence in either one working well for our patients. The other point to be made is that the axial SpA patients tend to be a little younger, and so are less concerned appropriately about some of the side effect issues that came out in the oral surveillance study with tofacitinib, in which patients were over 50 and had a specific cardiovascular issue, which got them into the study. Many of our AXPA patients and many of our PsA patients are much younger, and so this is less of an issue. So and some of it's going to be based on patient preference. Do I travel a lot? Do I do better with an oral medicine that I can carry in a pill bottle and don't have to refrigerate? That's one plus for the oral medication. Other patients just prefer oral. But then countering that is the fact that many patients have grown accustomed to using injections and so are quite comfortable with use of IL-17s. So I think it's really going to be on a patient-by-patient basis, and then presenting to them the efficacy and safety data, and then seeing which they prefer.